In summary, what I'm going to describe is the project, which is to automatically direct patients to appropriate clinics within the rheumatology department, patients referred by GPs, how we did it, the problems we encountered and their suggested solutions rather than the actual results, and the lessons learned for an NHS digital transformation that benefits everyone, basically, clinicians, teams, patients, and health organizations. So how did I get into this? I'm a late career NHS rheumatologist. In fact, beyond, I'm now retired from clinical work 3 years ago. Yeah, up to that time, I did 49 years of clinical work as a doctor. And I came during that time to realize that safe and effective medical practice relies on clinicians to perform a heck of a lot of boring, repetitive admin work, which is also highly demanding of their skills, judgment, and ability to deal with uncertainty. So I wanted to leverage that clinical experience and new technologies such as we're discussing now to improve the admin workload of clinicians. That is the basic aim. What problem were we dealing with? Well, the early treatment of rheumatoid arthritis is crucial for a good outcome. This has been realized for about 20 years. The earlier you get in, the better. If you can get the patient to the treatment within 3 months of the start of their symptoms, the long-term 20, 30-year outlook is dramatically better than if you wait a year. Rheumatology consultants therefore spend hours trying to pick out the minority of referrals with probable rheumatoid arthritis, RA, from the massive other referrals. But they also get a large amount of data, both text and laboratory and other imaging data from the GP, often as a data dump. Here's all our data on the patient. And GPs don't have enough time in their very short consultations to weigh the evidence. To compound the problem, there are also multiple referral routes to the rheumatology department, so it's extremely messy. And that diagram shows, in a nutshell, the dotted line is the division between the community services and, on the right, the hospital services. I can think of at least 4 ways that patients can be referred to the rheumatology department, 5 if you include referrals from other specialties such as emergency medicine. And the rheumatology admin staff corral all this information, pass it on to the relevant consultants, who then triage the patients either to an early arthritis clinic because they need to be, as I said earlier, patients need to be seen quickly, or those who don't need to be seen so quickly. And then all that data is entered into by the same admin staff into the electronic patient record, matched up with the blood test results, and the patient, when seen, is either discharged from the clinic or put into a commercial program called 4S Dawn, which is a monitoring program for blood results and an alert when things are going wrong in a patient who is on a drug that could poison them but also treat them, alerts the physician. Now, we started off with natural language processing of the text of GP referral letters. Dear doctor, could you please see this patient because he has pain in his joints, etc. And that's an example of what I would call a good referral letter. I would give it 60 or 70%. There's some important things missing there, but there's a key thing in that letter, which you'll see the initial CCP, which is a highly specific blood test for rheumatoid arthritis. If you've got that test strongly positive, you either have rheumatoid or you're going to get it, or very likely going to get it. So that tells us we need to act. Whereas not all the data is so great. That is a medication list, and it's ram-packed with metadata, which is irrelevant. Cliofem tablets, I barely know what they are, but does it really matter that Novo Nordisk make them? It's that kind of stuff that pollutes the doctor's mind when they're trying to decide what to do. Another polluting element is this problem list. This is a list of consultations over the years that the GPs send us. And you can see it's for everything: telephone encounters, acute pharyngitis. Which of it is relevant? You could spend 5 minutes going through that, weighing up each piece of it, but you can't. You don't have 5 minutes. You've got dozens, if not hundreds of these to do every week. So initially we started trying to recognize, using trained supervised AI, recognize rheumatoid arthritis from the text patterns in the GP referral letters, not from the medications of the problem list, just the text. Dear doctor, please see this patient, etc. The project design initially looked like that. Rheumatoid arthritis, break the referrals into rheumatoid arthritis and into everything else, which is not so urgent. But initially we hit straight onto problems. First of all, not enough rheumatoid arthritis as defined has been referred now or in the past to identify patterns and thus to train an AI. So we had to redefine the outcomes to aggregate the data into any inflammatory musculoskeletal condition and everything else. And actually it's a fortuitous thing because that is the group of conditions we want to see. Any inflammatory musculoskeletal condition could be 50% of it is rheumatoid, but there are a lot of other things: giant cell arteritis, polymyalgia rheumatica, SLE, gout, a whole range of things that benefit from early treatment. And of course, vasculitis, I left off that list as well, which is an emergency. The information in the text of the GP letters, as I said, ranges from nearly nothing, please see this patient and do the needful, really raises my blood pressure considerably because it says absolutely nothing, to too much. John has pain in his left big toe and and on you go. And that's also difficult to read. And this raises questions for the NHS as a whole about what are GP referral letters for? Are they just there to tick a box, or are they there to hand over important information? So we added basic blood tests, basic lab tests, blood count biochemistry, CRP, which tell a lot about a patient. There are just 3 groups of tests which are easily performed. Some of them could be done at point of care testing. All referrals now look like being distributed to, as you can see, are now distributed to all inflammatory conditions or non-inflammatory conditions. Everything else becomes non-inflammatory conditions. And then that's when we got our analysis going with analyzing the referral letter plus the basic bloods, bimodal AI, and it yielded the results you see there, which are not bad, but not fantastic. There's still a quarter of the patients where the accuracy is poor. So we started adding in other things, the medication lists that I showed you, specific lab tests for arthritic conditions, the ones I've listed there, past medical history, I've shown you previously the lists, and smoking and alcohol, which particularly smoking relevant to rheumatoid arthritis and alcohol to gout. We use different analytical methods, and sufficient to say the accuracy has improved, but it's all in press at the moment. The practical implications for the NHS are that they really need to do something about GP letters, and I think patients should also contribute, because there's some vital information to come from patients. It may be extremely wordy, but an AI could probably sort that out. Another problem, data anonymization. I think this is the biggest problem we deal with. Curation of training data to anonymize it properly is incredibly labor-intensive and requires a lot of clinical judgment. And we lack data scrubbing tools at the moment. The aim should be to never let identifiable patient and staff data out of the NHS. The staff part's often forgotten about. We have to watch out for pseudo-anonymization. For example, if the GP record says the patient is depressed and then it goes on to say that that's because her son is on trial for murder, you've almost identified the patient. Because thank God we don't have that many murders in the UK. And if you know the town the person lives in, you're home and dry. You can work it all out from there. You remove anything that could be linked with open source data, such as social media and newspapers. And you can see it's becoming a big ask now to anonymize things properly. So I can see only 2 possible answers in my clinical simplistic way. The one is to break the clinical notes into silos where there's anonymized data and identifying data, and I'll show you what I mean by that. And secondly, to import all analytical software into an environment within the NHS where it can be where this data can be analysed. I think the term sandbox is used for taking data away from the rest of the data and letting the analytics romp. And I think the sandbox might be very big. It might need to be as big as the whole database for some studies. But you can then play around, mess up the data if you want to, without touching the main database. That's the siloing I'm referred to. So at the top is the sum total of all the electronic records on each patient. And you break into 3 silos for argument's sake: demographics, anonymized clinical text, leaving maybe the bare bones demographics, the age in years and the gender of the patient. And then putting the metadata with all these detailed comments about murders, etc., somewhere else. And then just analyzing the anonymized clinical text. Bias, of course, everybody who works with AI knows about bias. Selection bias is always going to be a problem in training AIs, but fortunately, Reading is extremely diverse. The population of Reading is extremely diverse, so it's easy to train the data. We actually used aggregation bias to lump together disparate types of data, but we did it fully aware, and it's actually proved beneficial. Passage of time bias, your trained data becomes irrelevant as patterns of referral change. Confirmation bias you know about, and something I've suddenly realized, duplication bias. And I'll give you, it creates overfitting of the model and an over-optimistic result. For example, if you have a GP refers a patient, but sends in 3 separate documents with the patient data, that sends the text of the referral letter, another document, document B, with the text of the referral letter plus everything else on the patient plus their past history, and a third document just with their blood results, you could end up analyzing and discovering that you're doing the same data over and giving yourself an overly optimistic approach. Training of the system, as you would expect, using a dictionary and into breaking the outcome. You define your outcome and you break your criteria down in the dictionary into a high, medium, or low likelihood, and you can put together a couple of medium likelihood symptoms to make a high likelihood one, but not all, and that also requires clinical judgment. But an effective SDE, secure data environment, could dispense with all of this. And that is what the outcomes look like. A traffic light system, it's the middle one we want to work on, and to make it as small as possible, and that's where the clinicians need to spend their time. That is where the uncertain cases are going to be. As I've said, the patient, the referral data is identifier rich. They're codes, initials, nurse initials, doctor initials, all over the place. So GP data, and additionally, is sent through a horrible system called Choose and Book, and a simpler platform is needed. A Choose and Book's full of documents, different types of documents, different styles. It's very untidy, whereas hospital lab results are better warehoused. Electronic patient records vary. So the key problem is that in each type of data is in a separate database which can't communicate. They can't communicate with one another. And the answer is probably in specialty data warehouses to auto-curate, join up and analyze everything in milliseconds. Explainability of results, this is an important one. Healthcare practitioners are accountable for the actions of the machines they use, as we are accountable, as everybody is. You're accountable for the car you drive. The car doesn't have any authority. You do. Probabilities given by an AI have to be explainable and reliable, and that requires human supervision. So in conclusion, I think separate systems have to be proven in each clinical area and specialty, or a system has to be proven. You can't just take the whole thing and roll it out across a national system. It has to be every department, etc. You develop local systems that communicate with one another and with distant systems, and the gov.uk is an example. And you need fail-safe systems for false negatives. So there must be an alert challenge appeal mechanism. And that comes in at just before the EPR stage, once the patient's been allocated. So somebody who's sitting at home bedbound gets an 18-month appointment. They have an ability to say, this is complete rubbish, I need to be seen more quickly, and their GP likewise. But you can see this is a much simpler system running there. The automated machine triage, you could call it a washing machine. It looks like it in the diagram, takes all the data, analyzes it, and puts the patient in the appropriate category. Lastly, pajama time is a phrase used in the US to define doctors who sit at home in their pajamas with their hospital laptops doing patient admin. And that, I think, you can reduce that with this kind of AI. And this was decided I came across a 7-year-old slide recently, and it is exactly this that is happening right now in the US and in the Royal Berkshire Hospital, I know, and probably in many others. I don't want to go on now because I've overshot my time, but I just want to go to the bottom line. Digital transformation requires organizational transformation. You cannot do the one without the other. So to do that, you identify the problem, ask, is there a digital answer? And if there is, you then see how that answer fits in with the local organization. And it's better to transform the organization than to just impose digital transformation, which will fail. And lastly, thanks. I want to thank these people with whom I've worked. They have been absolutely crucial, and I'm grateful to them. Lastly, I just want to recommend a book which describes the gov.uk website, and it might well apply to a lot of what we do as well. Thank you.